Greetings. So let's continue with vaccination and just starting on with vaccine reactions that were covered in part one. Let's go ahead and do some applications. That's because um, whatever we acquire in terms of knowledge, we want to make sure we know how to apply it because that's when it becomes useful. So let's say I have a 15-year-old patient that comes to clinic for flu shot. So what were the three things to worry about? One, anaphylaxis to any of the ingredients. Two, decreased immunity. And three, when they got the shot prior, did they have fever greater than 104 or were they unconsolable? And again, a 15-year-old um, when they got the shot last year, the year before, would probably tell you if they weren't feeling well. So it's probably for the babies more than the 15-year-old. But anyways, that's our criteria. So let's apply it. The first criteria is no known drug allergy. So the patient comes in with no known allergies or drug allergy. So that means we're good. We can give them flu shot. Secondly, let's say, so is their immunity low? So let's say the patient has congenital immune deficiency. Ah, so the patient has congenital immune deficiency, right? Or she could be on chemotherapy, or she could be on biologics, or she could be pregnant. I don't know. But either of those things, let's say, she's got decreased immunity, right? Okay, let's take a look at the next thing. So when we're giving flu shots, you have an intranasal flu shot and an IM flu shot, right? Intranasal is live attenuated, whereas intramuscular is an inactive vaccine. So remember, live attenuated vaccines you can't give to somebody with decreased immune system. So because she has congenital immune deficiency, what's safe for us to give her would be an inactive intramuscular flu shot. Okay? See how easy this is? And again, the question doesn't give it, but we also inquire about whether they've had fever greater than 104, when they took the vaccine last. Okay? So you see how we were able to come up with the answer. So if you see a physician order for an intranasal flu shot or flu vaccine for this patient with congenital immune deficiency, that is something that we are going to go and clarify with the provider. That would be a safe professional. Okay. Okay. Let's go ahead and continue. Let's say a patient is a baby. Let's say a 2-year-old, a 3-year-old, and they received vaccine one, could be for anything, and had a fever of 102. Okay. Okay, they have and when they did, they had a fever of 102. They have no known drug allergies, and there's no history of decreased immunity. Okay, so the patient is healthy. There's no history of anything, and they have no known drug allergies. And the first time they took vaccine one, right, they had a fever of 102. So now we want to give the second shot for the same so it is second shot in the same series. So let's say it was vaccination against X. So again, they got the first shot in the series and now we want to give them the second shot, right? So they come in and the mama says, oh, the patient had fever last time. So you say, how much? It's 102. Okay. Patient previously healthy? Yeah. Patient with any low things to worry about in terms of low immunity? No. And then any drug allergies or known allergies? No. Okay. So what else would we inquire? Okay, consolable. Was the patient consolable the last time they got this vaccine? When they got the first dose of the vaccine and they had a fever of 102. So if the patient is consolable, and the fever was less than 104, it is a normal vaccine reaction. So you can give the vaccine. Okay. Okay, and again, if they were inconsolable and or the fever was greater than 104, then you don't. Sounds good? Easy, right? You know standards of care. Okay, what if patients refuse? Parents refuse, not patients, parents refuse. Actually, even patients refuse. But again, when it comes to vaccination, if there's a refusal, what do? First, we figure out the concern. If there's a medical concern, we educate them. If there's a religious or philosophical concern, we share with them the impact that the refusal to take vaccination would have with the individual and the impact that it will have on the community. And then again, we refer to the provider. Okay. So we educate and then we refer to the provider. Okay. So that's sort of very quick what to do when parents or patients refuse vaccination. Travel medicine, again, a very quick blurb. Concept is the person is going from where they're living, and that's when they come to you and they are planning to go to a destination. So the thing is there's some diseases that are common in certain areas of the world. So we figure out what the common diseases are in that area. And there's actually several websites that can help us figure that out. And once we do, we look at immunization against those diseases where the person is getting stationed and any prophylaxis that we can prescribe them that they can take with them so that that prevents them from coming down with that disease when they reach their destination. Okay, so again, they go healthy, they remain healthy, and they come back healthy. Okay, so that's just a very quick blurb. That's one of the big things in travel medicine. How do you know that the immunizations have worked? Okay, that's the other question. So again, after completing the vaccination series, we draw the blood for the marker for that particular disease. Okay, we give at least 4 weeks post-vaccination. A good idea is to give 6 to 8 weeks because that's usually the time it takes for the body to create its immune defenses to a level where we can measure it. Okay, so let's say if it's measles, mumps, rubella, varicella, these are diseases to which the immunity you become immune when you develop IgG antibodies against measles, mumps, rubella, varicella. So after 4 to 8 weeks of vaccination series being complete, we draw the blood, we measure IgG against these, and if they are high enough and past they are higher than the threshold, the person has immunity. Be a little careful because IgG would be a generalization. Sometimes diseases have their own serology as well. So most of them IgGs are good, but there's some exceptions like hepatitis B where hepatitis B has its own serology, and one has to interpret it to know whether the immunization has worked or not. We're going to cover this in infectious disease under hepatitis B. So if you're interested in looking at that one now, pause the video, go there, watch it, and you'd know. But essentially, it is we draw the blood to get serology for that particular disease. For most of the diseases, it's IgG against that particular disease. Immunization in pregnancy. Okay, what if you have a pregnant patient? If the vaccine is live and attenuated, don't give it during pregnancy. Okay? Okay. If the vaccine is live and attenuated and it's administered, wait for at least 4 weeks to become pregnant. So no getting pregnant for at least 4 weeks. Okay? Okay. And so that's the key is you can give immunization during pregnancy as long as it's not live attenuated vaccine. Again, for more specific information, you check the vaccine product insert. I'm giving you some general principles that keeps you out of trouble. So again, if it's a pregnant 15-year-old patient that comes into your office trying to get a flu shot, cannot give them intranasal. Okay, and that's so we can't give them live attenuated. And then for the other vaccines, we check their product insert. Okay. Okay, we've covered a lot of ground, but we shall continue. Let's talk about some individual vaccines. So again, we have Hep B, hepatitis B. We can give it during pregnancy because it's not a live attenuated vaccine. And then we have Hep B immunoglobulin as well. We have hepatitis A. We have influenza, so there's a nasal, which is live attenuated, and intramuscular, which is inactive. Okay. Uh, there's HPV vaccine, Gardasil. Again, you give it to males and females to decrease HPV. HPV, and that has implications for cancers of, again, we have genital warts and then also cancers like cervical cancer, oral, and cancers of the head and neck and anal cancer. But again, that doesn't mean we don't use safe sex practices and don't screen patients. We still have pap smears that we recommend women do, and then we still recommend safe sex practices. Because again, it's against certain strains, not all strains. There's a meningococcal vaccine, and again, this causes meningitis, very, very serious, and it's got very high morbidity, mortality. There's a vaccine against streptococcus, rotavirus. So these are all things to, and you can get some more information. I'm just covering some big vaccines that you're going to run into. MMR and varicella are live attenuated vaccines. Again, with MMR in particular, fever, rash, and arthritis. So it is normal for people to have fever as long as it's less than 104, okay? And a little rash and some, you know, joint pain and inflammation is common post-MMR vaccine, okay? There's HIB, Haemophilus influenzae vaccine. And again, that's to decrease risk of HIV meningitis. Again, meningitis, kind of big deal. We don't want it. Polio, there's oral polio. It was live attenuated. It's fallen out of favor. So again, we give the inactive polio vaccine, which is IPV, and that's the one that's preferred. Um, so that's polio. Let's talk about a couple of them, which are really important, and spend some more time with them. There's diphtheria, tetanus, antipertussis, and tetanus. So you have diphtheria, so that's the D. You have the pertussis, and then again it's antipertussive, so it's AP or P, right? And then it's tetanus, so that's T. Okay. So again, you have DTaP, Tdap, and TD. Oh my God, what is this? DTaP, diphtheria, tetanus, antipertussis. And then you have Tdap, tetanus, diphtheria, and antipertussis. Well, what's the difference? DTaP you give to kids. Tdap you give to adults. How do I remember it? T is for teenagers. Okay. So anybody who's a teen or over gets Tdap, greater than 10 years. Okay. And then DTaP is given to kids. Okay. And then TD is just a tetanus booster. So again, we want to make sure we are keeping the tetanus, we're giving them the boosters so that they remain immune to Clostridium microorganism that causes tetanus. Okay. So let's kind of talk a little bit about tetanus. It's very, very important because it's very easy to get. And once you get it, it makes you very, very, very sick. However, within vaccinations, we can actually prevent it 100%. So what's the algorithm? What's the thought process? So let's take a look at it. So the first question you ask is somebody comes in with a wound. So they've injured themselves and there's a wound. So the question is the wound clean? So what's the definition of a clean wound? Okay, it is not penetrating. There wasn't any rust involved with whatever caused the injury. There's no saliva, soil, feces, or metal. Oh my God, that is a lot of criteria. So here's kind of my take on this. There is a very, 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 very narrow definition of a wound that's clean. So the wound that's clean is not penetrating, not caused by object which had rust on it, saliva, was contaminated with soil, feces, and was caused by metal. Okay. If all of those things are true, then the wound is clean. If not, the wound is dirty. So was the wound penetrating, and was the object that caused the wound had contamination with rust, saliva, soil, feces, and was it a metal? If the answer is yes, the wound is dirty. Okay. So now you know if the patient coming in has a dirty wound or a clean wound. So let's take a look at what the tetanus algorithm is. So we look at the total number of boosters and tetanus shots that they've gotten. If it's less than 3 over their lifetime, okay, then that means they have low likelihood of immunity against tetanus. If they have received greater than 3 shots of tetanus, then there's an increased likelihood of immunity, right? Good. So let's talk about if there's an increased likelihood of immunity and the wound is clean, they require nothing. If there's an increased likelihood of immunity and it's dirty, give them a Tdap. Okay. Let's say if their tetanus shots are less than 3, that means they have low likelihood of immunity. So if the wound is clean, just give them a Tdap and they should be good. That's because we don't know if they have enough immunity to tetanus. If the wound is dirty, I'm going to give them both Tdap and give them immunoglobulin against the tetanus toxoid. Okay. So if you see here, if the wound is dirty and they don't have enough shots in them, which is less than 3, they get the big guns, Tdap and IVIG. If the wound is clean and they have good immunity, they get nothing. Rest all of them get what? A Tdap and get sent home once the wound is managed. Easy, right? One more time. Tetanus. If the wound is clean and they got good immunity with tetanus greater than 3 shots that they've received, whether it be Tdap, DTaP, or TD, guess what? They don't need anything. If they have shots less than 3 and the wound is dirty, give them everything, Tdap and IVIG. Rest everybody gets a Tdap. Easy? That's why you listen to this, because I make it easy. But that's standards of care. So when you see questions and you see what you're thinking, you have patient coming into ER with an injury and it was a dirty injury, and the next appropriate question is, how many shots have you gotten? And if there's good evidence, then that they've gotten greater than 3 and it was a dirty wound, then what do I do? Versus if we don't know how many shots they got, what do I do? And the wound is dirty. Or if the wound was clean and you know what, they have good number of shots in them for TD, what would be a good thing to do for the patient, right? Good? Perfect. So that's tetanus for you. The next is Rhogam. So this this takes a bit of time. So let's talk about it. So essentially you have red blood cells, and red blood cells have an antigen on them, which is Rh antigen. So either you can have a antigen which is Rh positive or Rh negative. That's why you have A plus, A negative, B plus, B negative, AB plus, O negative. So it's the positive and negative is that Rh. Okay. So there's actually three antigens we consider, A, B, and Rh. So O negative does not have A, does not have B, and does not have Rh. A positive has A antigen and Rh antigen on that red blood cell. Okay, so that's the concept, more details in hematology. So again, watch out for that video. Okay, so what does that mean? Let's say I have Rh negative. That means, guess what? The RBC does not have an Rh antigen. Okay, so what happens? So if this person let's say injects themselves with a needle and that needle was in somebody else's vein and blood supplied with an Rh positive blood, so now the person with Rh negative antigen got exposed to Rh antigen, and now they can create an antibody against Rh antigen. Why is that? Well, here's a good reason, because even if they create an antibody, it's okay because that antibody will not tag them. Okay. So again, that will be a good antibody, but it's not going to tag their RBCs. Okay. It's just going to float around. Okay. So that's a good thing. So now, and that's what I'm talking about here, will it impact the patient's RBCs? No, because we don't have any antigen that the antibody can tag in the patient. Okay. Now, can an Rh positive red blood cell develop antibodies against Rh antigen? So let's say it's another patient, he has Rh positive red blood cells, right? He gets exposed to Rh positive blood. So can that person develop Rh antibody? Answer is no. Why is that? Because his blood has Rh antigen, okay? And if I have an Rh antibody floating around, which is going to tag my red blood cells, immune system is going to take out this red blood cell once it's tagged. That's the function of immune system. If you're not sure, look at my anatomy and physiology videos. So an Rh positive patient will never develop antibody against Rh antigen because all the RBCs in that person's body have Rh antigen, and we don't want the red blood cells to be tagged and killed by my own immune system. Okay? If, however, I'm Rh negative, I can develop antigen, but you know what? That antigen, that antibody. So again, if I am Rh negative, there's a possibility I can develop that antibody. However, that antibody is not going to impact me. Why is that? Because I don't have an Rh antigen. Okay, well, that was a long story. So what's the problem? Seems like if I have Rh positive, I can't develop the antibody. And if I'm Rh negative, I develop the antibody against Rh antigen, but it doesn't affect me. So why am I talking about this? Well, here's the deal. So in women that are pregnant, let's say the women that are pregnant are Rh negative and the baby is Rh positive. And for some reason, the mama gets exposed to Rh positive RBCs. Now they will develop antibodies to that Rh antigen, which is not going to bother mama one bit. But that antibody is going to cross the placental barrier and and actually tag babies' RBCs. Ah. So an pregnant Rh negative patient having an Rh positive baby. That's the problem. So what happens is you have exposure of Rh negative mom to Rh positive baby blood. Okay. And then what that does is mom develops antibodies against Rh antigen. Okay. Right? So here's mommy, and here's baby, and here's the placenta. And for some reason, mama gets exposed to baby blood, right? Or another Rh positive blood, maybe because of transfusion, maybe mom was doing needle drugs, right, in the past or now. And then what happens is now mom actually develops Rh antibodies to Rh antigen. Okay, so usually if it's the first pregnancy, that's when the antibodies are developed. Okay, so it doesn't affect that baby as much, but the subsequent pregnancies, now you have the antibodies already in there. So they cross. So here's mommy. This is her RBC, and then you have the antibodies. So they don't affect mommy, but they cross over and they start to tag baby red blood cells. And when they do, these blood cells in the fetus get tagged and destroyed. So when that happens and baby RBCs are destroyed, what would you see in the baby? Anemia and heart failure and edema. That breakdown of blood will cause jaundice and brain damage, and that's called kernicterus. Okay, you will have hepato and splenomegaly. The fetal body is going to go into overdrive, and it will, like crazy, produce red blood cells and kick them out even before they mature because the body is not having enough RBCs in them. So you'd see a lot of immature RBCs. It's called erythroblastosis fetalis. Okay. Okay. So it can have some serious impact on the baby. Okay. All related to those RBCs being tagged and destroyed. How can I prevent this? How can I prevent this? So when we are thinking about preventing it, there's two questions to ask. First, when is there increased risk of sensitization? Because what we are doing is sensitizing mama to Rh positive blood. So when are we doing that? Whenever the placental barrier is broken and the blood from both sides can intermingle. Okay? Or we give mommy, we expose her body to Rh positive blood. Those are the two possibilities. So, eruption of placentas during labor delivery, ectopic pregnancy, abortion, abruptio placentae, and several other things that you'll see with placenta. If you're doing procedures that are very invasive, like amniocentesis, those are all very, very invasive procedures and can cause abruption of placenta. So when that happens, there could be sensitization. What about Rh positive blood? If I give somebody blood transfusion or they're doing IV drugs, those kinds of things, now they can also develop those antibodies. Okay. So that's when the sensitization happens. So what can I do when the sensitization happens? Well, let me give an antibody to the Rh antigen, and it's called Rhogam. So let me share with you. This is mom's blood. This is baby blood. Now, mom's blood got exposed to these baby bloods. Okay, these are babies. These are smiling. Baby bloods. Okay, and this is mommy. Okay, she's also happy. Okay, and they expose, again, baby blood exposed mommy. So I give Rhogam. Rhogam is nothing but antibody to Rh antigen on the baby blood. So when that is done, the Rh antigen tags the baby blood. The Rh antibody, so Rhogam antibodies now tag the Rh antigen on the baby blood. When that happens, this gets destroyed and the mom's body is not exposed or is not looking at the antigen because that antigen is now connected to an antibody. Okay, and that's a good way to think about. That's the way I think about this: is when antigen antibody get together, that thing is tagged and killed, and the body doesn't get to see that antigen, so it doesn't make any antibodies. And again, that antibody to Rh antigen does it and then is done, and then it gets excreted out of the system, and you're all good. And the mom doesn't develop antibodies to Rh antigen. When do I give it? I give it after labor and delivery. Okay. For normal labor and delivery, 28 weeks and 72 hours after delivery. And then if there's any of these special conditions, then again, as soon as I can. So again, antigen is tagged. Mom's body is not able to see the antigen, thus does not produce antibodies, so no issues. So that, ladies and gentlemen, is Rhogam. And it is one of the marvels of modern medicine because it allows mothers with Rh negative blood to have subsequent pregnancies that are normal. So let's just go through real quick what we covered in this lecture. So the first thing we did was we applied vaccine reactions and the principles. We talked about parent refusal or patient refusal to vaccines, what to do, travel medicine, how do we know the vaccines are working, immunizations during pregnancy, and some of the principles. And then we continued on with some important things about some specific vaccines. We spent some more time on DTaP, Tdap, and TD, just because from a vaccination perspective, they're very important and often very confusing to students. And we also spend a bit of time on Rhogam, because that's the other thing that confuses people is why would antibody against Rh antigen prevent mama from making antibodies against Rh antigen and prevent issues with baby in subsequent pregnancies. So again, when you review this, it should make perfect sense to you. Um, Thank you.